Preventative cardiology operates on a central observation. Circulating apolipoprotein B, or ApoB, the primary protein carrying bad cholesterol, causes atherosclerotic heart disease. The risk of developing that disease scales directly with the magnitude and duration of your exposure. The longer these particles circulate and the higher their concentration, the faster this line curves sharply upward. Adults carrying LDL cholesterol levels of 190 milligrams per deciliter or higher cross the threshold into severe hypercholesterolemia. Clinically, this signals a significant lifetime risk for premature cardiovascular events like heart attacks. Yet, routine medical practice repeatedly reveals a puzzling subgroup of patients. Cardiologists call them escapers. Escapers carry sky-high lipid levels. They spend their entire lives bathing their arteries in high concentrations of cholesterol particles. Despite this relentless exposure, they reach midlife and sometimes their senior years with no clinical manifestations of coronary disease. No heart attacks, no chest pain, no restricted blood flow. Even when doctors scan their hearts, they find a total absence of detectable coronary calcification. The physical disease is simply not there. These escapers almost universally share one trait: a multi-generational family tree with no history of heart disease. It forces a central question: does a pristine genetic pedigree act as a biological shield against a lifetime of cholesterol exposure? To find the answer, we have to look past the bloodstream and examine the physical tissue of the artery itself. This is known as the response to retention model. Flowing ApoB particles cross the endothelial barrier and become physically ensnared in the tissue matrix. The trapped particles degrade, triggering an alarm. Immune cells swarm to consume the cholesterol, transforming into foam cells. These build up, calcifying into a rigid, expanding plaque deposit. The genetic susceptibility theory suggests that escapers inherit a uniquely resilient vessel wall. Their arterial lining might be less permeable to particle entry, or naturally programmed with a lower inflammatory response when those particles do get stuck. In this framework, family history encodes a biological resistance to the particles flowing through the system, rather than a lack of exposure to the particles themselves. To test this resilience theory in the real world, researchers turned to a specific population, the Pennsylvania Amish. Because they possess a highly homogeneous genetic background and share similar environmental exposures, they provide remarkably clean medical data. A subset of this population carries a specific mutation in their ApoB gene. This mutation causes severe, lifelong elevation of LDL cholesterol from the moment they are born. When researchers examined Amish youth and young adults carrying this mutation, they found no early evidence of vascular injury, despite massive, lifelong lipid burdens. The biological shield theory appeared to hold up, but long-term follow-up studies showed that this immunity is only temporary. This bar chart compares the rate of detectable coronary artery calcium in middle-aged Amish adults. It shows that mutation carriers were roughly 4.5 times more likely to have hidden calcified plaque than non-carriers. Resilient genetics don't confer absolute immunity. They put the disease in slow motion. A favorable genetic background allows the artery to resist injury for decades, but eventually the relentless physical pressure of ApoB exposure breaks through. This shifts how clinicians categorize a negative family history. It is a risk modifier that changes the tempo of plaque development, not a biological shield that neutralizes risk. Rather than guessing a patient's timeline based on a family tree, modern clinical practice relies on looking directly at the artery for hidden disease. Doctors do this using a coronary artery calcium, or CAC scan. This scan introduces the clinical power of zero. If an escaper patient with severe hypercholesterolemia receives a CAC score of exactly 0, the data shows their short-term risk of a heart attack is exceptionally low. This delayed timeline comes with strict exceptions. The slow motion effect is immediately voided if the patient has other inflammatory accelerators, like a cigarette smoking habit, diabetes, or elevated levels of a highly inflammatory cholesterol called LPA. Inheriting a resilient cardiovascular system buys a patient decades of time. That extra time justifies a highly personalized, unrushed approach to medical intervention. But given enough time, no one can permanently outrun a lifetime of toxic cholesterol exposure.